Thank you very much. Thank you for, inviting me, and it's a pleasure to be here. It's certainly a little surreal to be on the other side of the Friday OEH seminar, but nonetheless, here we are. I'm going to go ahead and share my screen. Um, I would like to as well express gratitude to, just one sec here. Express my gratitude to the committee as well. So that's doctors Karen Bartlett, Yogesh Thakur, and Sarah Henderson. And honestly, without them, I really would not be presenting today. So very much appreciate all their work and support in helping me do that. And welcome to the new students of OEH. It's a very exciting time. And I'm sure you just can't wait for all the Friday seminars. So thank you for listening today. So let's get into it. The very first poll question: the eye lens is one of the most radiosensitive tissues in the human body. And so 50-50 chance here, true or false. Everybody's doing really well. Yeah. So we can keep that running as long as you like, Angela, but we're looking good. So it is true. So the eye lens is one of the most radiosensitive tissues in the human body, and this has been known for quite some time. This goes back to some of the discoveries of even gamma radiation and if I can pull that down just a little bit, and photosensitive, photographic paper as well. How can I? There we go. Henry Becquerel's discoveries with gamma radiation and photographic paper. So it's been known for quite some time. I'm not the first to study, and nor will I be the last. And so this kind of makes it an exciting opportunity to review something that has been studied for quite some time. There is quite a bit of research, and there's evolving research as we go along as well. So very quickly, we have a couple things to do for a background here. So the electromagnetic spectrum, we're going to review this very quickly. Of course, we have everything in non-ionizing radiation, from radio towers to the cell phones that we use, televisions, and Wi-Fi, ranging all the way across as our wavelengths decrease to things like gamma radiation or X-ray radiation. So a few examples over here. Sometimes we go to the airport, they look through our equipment, or we get an X-ray on our body. And so this was one of the first discoveries as well, as we started developing X-rays and looking past our hands into the walls, we could see that there was actually casting an image to the wall. And so that's also one of the part of the first discoveries that something quite interesting was happening here. So our study focuses on X rays and gamma rays. Those are photons, and it does not include any particle radiation. So that would be alpha or beta radiation. So what kinds of things are we talking about in healthcare that might be using radiation? So one is nuclear medicine. A few things here you can see that are quite interesting. Of course, here we have the medication itself, and we can see that this is shielded pretty significantly here by some lead tubing. And so that helps with some of the decrease in exposure for the nuclear medicine departments. And then we have interventional activities as well. So this is a C-arm fluoroscopy unit that can measure, that helps surgeons or beyond really take a look at the body and use X-rays essentially in real time. There's a few advantages to this, of course. So if we can X-ray and take a look non-invasively, it can help surgeons reduce the amount of operation time, but also the amount of potential incisions that need to be made, and really focus on the priority areas. So these are two kind of different examples. One might be from gamma radiation here, from the decay of nuclear medicines. Of course, we also use that in imaging as well. And of course, the interventional technique. So this is really a key component to this study that we're assessing nuclear medicine and interventional samples. So a primer, and pun intended here, but our focus here, of course, is on the eye lens. So we know already that this is one of the most radiosensitive tissues in the human body. The mode of action here, or potential tissue reactions, are essentially, what's been proposed and mostly accepted is that radiation can damage some of the cells at the anterior pole of the lens. And these cells would travel to the posterior aspect of the lens. And this could potentially disrupt, create a tissue reaction like a cataract. And this could disrupt light projection to the back of the retina. So of course, if light projection is altered or changed, or it's not coming in effectively, then what's understood by the brain later on can be certainly challenged. So that's the general sort of mode of action for this type of tissue reaction. There are multiple different kinds of cataracts, and so it is truly on its own almost a whole other topic as well. But for the most part, radiation and potential radiation exposure may cause something like a posterior subcapsular cataract. One final little thing that I think is really important that we discussed very quickly is this idea of deterministic effects. So in this scenario with a tissue reaction, it's widely believed that there's a threshold dose of which where dose is potentially zero. At a certain point, incidence of effects will increase. And so it's not, this curve obviously does not start initially at zero, but well after zero. And so this threshold dose here is what's really studied the most to understand. Of course, in hygiene, we're always interested in sort of exposure limits and action limits. And of course, this threshold dose is what's continuously being studied to understand more about that. So second question, the occupational exposure limits to ionizing radiation do not change. All right, so we got a decent little split here. Thank you. All right, so like any evolving exposure limit, whether that's a physical hazard or a biological hazard or a chemical hazard, the exposure limits can certainly change. And so that was really the impetus for this study. And so we'll get into that next, just quickly here. So that is, of course, false. And that really does speak to some of the importance of the study. So potentially ionizing radiation exposure may cause opacities or even cataracts. Widespread, there's about 48,000 Canadian medical workers exposed to ionizing radiation every year. And of course, there's a whole system behind licensing and control and protection. But previously, the exposure limit to the eye lens was 150 millisieverts equivalent dose per year. And so one of the new exposure limits, I should say, is a 50 millisievert dose, equivalent dose per year. And so that was effective December 1st, 2021. So at 150 millisieverts, that's, probably unexpected that we would see that. At 50 millisieverts, it would be an interesting opportunity to take a look at, what might be the current dose. And so our focus, again, are those nuclear medicine and interventional groups. And my final poll question, so eye lens dose can be predicted from collar, chest, fetal, or ring dosimeters. All right. A couple final guesses. All right. So if you answered this question, you got it right. The eye lens dose can really be predicted from any of the dosimeters. And so that was another objective of this study is in order for us to understand true eye lens dose, what we would likely have to do is get a dosimeter as close as we can to the eye lens. We know that implanting a dosimeter in that area is not ideal. And so we do try to get it as close as possible, meaning that if we have a dosimeter at our eye, and then we have another dosimeter at our collar, and we have another dosimeter underneath the lead apron at the chest, another fetal dosimeter, and a ring dosimeter, yes, it is possible for us to predict those, although due to the fact those are at varying distances, depending on many factors, the height of the interventionalist or nuclear medicine, professional, or even the height or size of the patient or the type of task, many things can change. And so if you think that wearing an island dosimeter and a collar dosimeter and a chest dosimeter and a fetal dosimeter and a rig dosimeter are a lot of dosimeters, you are right. And actually, there are staff wearing all of those dosimeters during particular times. So getting them to wear one more dosimeter is certainly something that we want to look into. And so we did as well take in staff feedback as well. So if you put an answer in, you were correct. So hopefully you're 3 for 3. All right, so what are the objectives of this study? Well, we talked a little bit, number one, measuring annual equivalent dose. Okay, so equivalent dose is adjusted for the potential, it has an adjustment factor based on the type of radiation. So in this case, we're talking only about photons. We're going to model potential predictors. So we took a whole bunch of variables, including location, department, what else? There's a few more in there. And then we model those potential predictors to see, are any of those changing? And based on the collar, or excuse me, based on the dosimeter, can we predict islands dosimetry from other dosimeters? And then, of course, you want to identify potential follow-up in the study. So how do we do this? Okay, so bear with me. We're going to start with a blank slate here. We had 7 hospitals, okay? A, B, C, D, E, F, and G. They're not actually called that, but for the purpose of this demonstration, that's what they'll be called. There were 3 health authorities in British Columbia. We have a number of health authorities all the way across the province. So there's Health Authority 1, Health Authority 2, and Health Authority 3. As you can see, Health Authority 1 provided 3 hospital sites. Health Authority 2 provided 3 hospital sites, and Health Authority 3 provided 1 hospital site. All of these hospitals belong to what's known as Lower Mainland Medical Imaging, which is an amalgamated group of professionals who look after radiation safety here in the Lower Mainland. Again, we have 2 groups that we've defined for this study, which are nuclear medicine and interventional. So hospital A, B, C, E, and G all provided observations from nuclear medicine. D, E, F, and G all provided observations to interventional. And you can see that hospitals E and G also provided, they're providing observations to both groups. All right. So within those hospitals, who was included? So included in these groups were based on proximity and duration. So those performing interventional or nuclear medicine techniques within 1 meter of the patient. Full-time staff and experience was greater than 2 years. We excluded those working at more than 1 site, exclusive use of the mini C-arm, so a smaller fluoroscopy unit, project control or charge nurses, staff with intermittent access to our sites, or multi-site casual employees. Here is a list of, if you want to know even more about the different departments and groups that were involved. So we have catheterization lab, endoscopy, nuclear medicine, orthopedic surgery, radiology, urology, and vascular surgery. All but the technologists in nuclear medicine were assigned to Lower Mainland interventional. So nuclear medicine technologists were all assigned to Lower Mainland nuclear medicine. And again, when we go back to all the way to the beginning, we're seeing a much different type of task between these 2 groups. Hopefully you're still with me. All right, so wear instructions. There is a lot of research on how it should be worn. And so certainly this project was completed during the pandemic. Certainly some challenges in terms of getting to staff and using reminders and things like that. But there is a more acceptable way of wearing this dosimeter, and that's so that the label faces away from the body, closest to the most exposed eye. Okay, so if a right-handed interventionalist or surgeon is operating, then it's likely the left eye is most exposed as they lean in. And so the eye dosimeter would be assigned to the left eye. If we have to wear caps, the surgeon or interventionalist has to wear caps, it would be clipped in on or in the cap. And so we're wondering, oh, well, we don't see it on the outside here. Actually, on the other side, it is flipped over. The cap is just covering that space. And how do we get this data? So the hospital assigned, distributed, collected dosimeters. This is a routine requirement as per their license with the Canadian Nuclear Safety Commission. Dosimeters are sent to Landauer, so that's a third-party dosimeter reading organization. They're likely the biggest in North America that I can think of. Medical Physics retrieved data from the secure Landau online portal. This data was processed and blinded to myself for data analysis with a reverse entry key. So in the event that we found something that was beyond an exposure limit, we had the opportunity to go back to staff and tell them about their dose. We anonymized the data and used an encrypted shared drive only for my access. Okay, all right, the moment we've been waiting for. So the results. We had over 10,000 total observations, including all quarters, dosimeters, and values that are NA. Values that are NA are those values which are below the limit of detection, which in most cases was 0.1 millisieverts. And so that N was 10,331. These are not participants, these are observations. So for example, one participant may be wearing up to 5 dosimeters, and so they would have 5 observations, although they are one participant. It should also be reviewed that the quarters that were used, we ended up using 2 quarters. So the data I'm presenting today is from 2 quarters, although we continue to accept more data into the study, and so you know, more data analysis collection is ongoing. But for the purpose of today, this is from 2 quarters. And interestingly, these quarters are the quarter before and after the new regulation came into place. So we removed all observations which were less than the limit of detection for all dosimeters. Each dosimeter may have a slightly different limit of detection. And so that was 9,176 observations were removed, leaving us with 1,155 observations. We selected the highest dose reading for each participant. So if the participant had 2 readings, which were over the limit of detection, their highest dose would have been accepted into the study. If they had 1 reading and the other reading was below the limit of detection, their 1 reading would be selected into the study. And of course, if both readings were below the limit of detection, neither would be selected for the study. And so 377 of those observations were removed, leaving us with 778 total observations. Just a graphic here on what we're talking about for those values the values less than the limit of detection. So for lower mainland interventional, 8,279 observations were below the limit of detection. Only 639 were greater than the limit of detection for a total of 8,918. Lower mainland medical imaging, you know, about 50-50, less than limit of detection and greater than the limit of detection. For these groups, we're taking a look at the N value here. So these are participants and their remaining I dose. So the median for interventional is 0.46. with a mean of 1.17 millisieverts, a max of 8.46. We'll get to that in a second, and a standard deviation of 1.97. So we can see, a higher level of variance here for the interventional group than the nuclear medicine group. We have a geometric mean of 0.52 and a geometric standard deviation of 3.14. 94 total participants for nuclear medicine, with a median of 0.24, a mean of 0.32, max 1.05, standard deviation much smaller, as well as the geometric standard deviation. So these max readings are what we're going to get into next. All right, so here's one of the study's real final, well, they're all real final results, but this is probably one of the biggest takeaways. So on this box plot, we have lower mainland nuclear medicine and lower mainland interventional. On the y-axis, we have what we're calling unattenuated, meaning that these readings from the islands are coming directly to the island's dosimeter. And so our staff are also wearing leaded glasses, which are also going to attenuate some of the dose. And again, we'll get into that a little bit more into that in a second. So these are unattenuated. These are the log values of the island's dose readings. The reason we're using the log values here is because of a significant right skew in the data distribution, and it was more normalized. I mean, as you can see as well here in this box plot. So here in this box plot, we have the 25th percentile, the 50th percentile, and the 75th percentile. Anything beyond these lines are potential outliers. So we see lower mainland nuclear medicine of a log value of negative 0.5, and lower mainland interventional about 0.32, I think it is. So what's interesting though is we look past the 25th percentile here, and we end up finding, we look past the max values here. We don't find some potential outliers. So this red line goes across at a quarterly limit. So this would be 1/4 of the proposed occupational limit. And this is our action limit, 50% of that. So what we did find were some potential dose here that were actually beyond the potential action limit. Again, this is quarterly data and unattenuated. So assuming that there were no leaded glasses worn, this could be the potential dose. Although we do know that lead glasses are worn, and they are significant attenuators of photon radiation. All right, one of the bigger takeaways here on the second one is, can we predict eye-lens dose from collar dosimeters? So we're wearing a collar dosimeter. The advantage of the collar dosimeter is that, again, it is also unattenuated, okay? So in Canada, we wear the dosimeter for the chest underneath the lead apron. And so that actually, again, is being attenuated. So it makes it a lot harder to predict, although the third-party administrator does provide a potential equation to formulate that. We found that the color dosimeter and no other variable, actually, including department or hospital site, was most predictive of eye lens dose, with an R-squared coefficient of termination of 0.69. So, moderately well explained. I think, we'll get into some of the conclusions as well. So some of the strengths of the study, this was obviously a very large sample size here in the lower mainland. Of course, this could be expanded to some high priority areas within British Columbia. These are pretty complex groups. So the types of tasks that are being performed are quite complex. There are so many very interesting studies within this field, from projection of dose based on based on artificial intelligence. There's a lot of really cool stuff going on in there. So this study hopes to speak to that as well, using some human data. It's a pretty robust data capture via multiple dosimeters. So we talked about the fact that we may be receiving dosimeter information from 4, 5, 6 dosimeters, and that allows us to really make a lot of pretty interesting comparisons. The findings were consistent with the existing research in terms of the lower dose within nuclear medicine, and the interventional techniques potentially having a little bit higher of a dose for a few reasons. There even within those, there are particular surgeries that create a little bit of a higher dose. For example, spinal surgeries and hand surgeries seem to create a little bit of a higher dose for surgeons, and the secondary staff, which are helping with the surgeries as well. That being because there's a little bit more fluoroscopy time, so it's consistent with that type of research. And we did find an adequate, pretty moderately well-defined predictive model and curve. Yeah, I think the data infrastructure is pretty good. So of course, having coded it in, I think there is an opportunity here to, the data is reproducible, it's clean, and so there's a possibility here for personalized dosimetry to connect with the data that we've created. So since we started this study, Vancouver Coastal Health has launched some very interesting apps and whatnot that can log dosimetry as well. So it's possible that we could connect with that. Of course, there's room for growth. So going into full year exposures, expanding the groups, or even some type of case control where because we know sometimes these tissue effects could come later on in the form of like tissue reactions or cataracts, we could potentially look at a case control study where we look at dose from the past and potential outcomes in the future. Some of the limitations, so for sure, COVID-19, challenging time all the way around, specifically for the hospital. While I always wanted to make this the highest priority, the hospital certainly had a lot of priorities. So, secondary data analysis being that it's not observational. The original study design would have had more observation opportunities. So going and watching, making sure people are wearing the dosimeter, staff are wearing the dosimeter in the ways that we've prescribed. And it made it a little bit difficult to correct action. So, that just being, if a dosimeter was worn incorrectly, it's a little bit challenging to find out because we're really reporting on a quarterly basis. So, you're talking maybe 5-6 months later where we would end up probably correcting that action. And of course, some limited job classifications, although, kind of wholesome. So in conclusion, what did we do? So what? So we're going to continue interventional eye-lens dosimetry. So for those groups and departments that were assigned to the interventional group, whether that's orthopedic surgery, endoscopy, anything like that, eye-lens dosimetry does continue. Because of the low exposure, it being consistent with research, moderately predictable from the color dosimeter. So we maintain a color dosimeter, we can make a pretty good prediction as to the eye-lens dosimeter. And this is probably a better opportunity for the best use of resources, reassigning the dosimeters to an interventional a group that could use some assessment as well. And that is it. I really want to thank everybody for listening very much, and also shout out to my family who's watching today. So thank you for attending. Thank you.